Thank you, David, for a kind introduction. Thank you to Director Botticelli, Director O'Donnell, Superintendent Stickrath, our Executive Director, Mike Thompson. Couldn't have asked for a better setup for the comments that I'm going to share with you. David and I are actually splitting this presentation over the next hour for our attention to behavioral disorders and their impact on problems in corrections and reentry. We want to focus on that for a couple of reasons. One, the high prevalence rates, which I'll share with you in a moment. But secondly, as one of the themes of our presentation, is that in working with individuals with behavioral disorders, the way in which we assist them in not returning to correction settings has a lot of overlap and commonality with all the people that we work with. And so it's with that theme in mind that I want to present to you a few comments. I also have stood in the back, and the screen is really small. So I understand that as we tell this story in pictures, it may be a little difficult to see, but we do have this presentation available on thumb drive and also available at our website, and encourage you, if you have questions about the slides, to look at those particular sites. What we intend to do is to provide an overview of mental and substance use disorders in the criminal justice system, and then turn it over to David to talk about risk, need, responsivity, our behavioral health framework, and the applications of the framework to the work that you do. We have this scenario, which you're all aware of, an expanding and growing population of adults, and I'll be focusing my comments on adults, under correctional supervision, with about 750,000 in our jails on any given day, about 1.5 million in our prison, but importantly, over 5 million of these individuals under community correction supervision, the folks that you work with, you on the front lines, and you know these people well. We have the dubious distinction of having 5% of the world's population, about 23% of the world's prisoners, and we're all about figuring out how to preserve public safety and at the same time assist those individuals in returning to community and returning to productive lives. We can celebrate in part a recent decline in our state prison population, first decline in almost 40 years. It has been varied, though, across your states, and that I'd ask you to think. You can't see where your state is on this graph, but some states have populations going up and others going down, and we have to understand what it is, what the recidivism rate is in your state, in your county, in the programs that you work in, to understand if the impact of your program activity is having the desired outcomes that we all care and value. Last week, the Bureau of Justice Statistics added this data to our armamentarium, and that we have a declining jail population as well. The bars are the number of individuals within jails. The red line is actually the rates of increase or decrease. But this, too, is a phenomenon that we're watching closely and moving forward hope to see, again, as possible outcomes from the work that you do. It hasn't been an even, though, success in terms of assisting people to come out, land on their feet. And in this slide, from work that we had an opportunity to do at the request of the Bloomberg administration in New York, we were told and see that the average daily population within Rikers Island, the New York City facility, went down considerably from the years 2005 to 2012. The gray bar, gray components of the bar, however, suggest that for those individuals with mental health issues, they actually went up in number. And so we need to understand what contributes to that so that we can design effective responses and perhaps mitigate this phenomenon. We all understand the scope of the reentry challenge. That's why many of us are in this room today. 1 out of 33 adults under correctional control, over 90% of them are going to be returning to our community, and the stats aren't very pretty in terms of almost 70% returning to state prisoners rearrested after 3 years. And that's what we're trying to impact, and that's what we hope to share with you, and that's what many of the workshops over the next day and a half will focus on, ways to change that particular phenomena. It's not a random group of individuals that are in our correctional settings, under correctional control, men more than women, across racial lines, white men, 1 in 45, black men, 1 in 11. And it's these phenomena that we need to understand so we can design culturally responsive and appropriate interventions that address and respect the cultural differences that are in the populations that we work with. We also have a graying prison population at this point in time. So the green line on the top is the absolute number of individuals that are in our state prisons with age 55 or older. This has enormous implications for the type of services that they need, the employment that they'll have access to, the chronic health conditions that need to be addressed and needs to be accounted for in the work that you do. We also are aware of a substantial increase in the number of women under correctional supervision. And this slide looks at women in orange in the federal prison system, in blue in the state prison system from 1980 to 2010, and you can see that steady increase, so that gender becomes an important component of our treatment and supervision strategies. And to follow on to Director Botticelli, we have a growing number of individuals in settings that got there as a related to drug-related offenses. The blue bars, 1980, the orange bars, 2010, and from left to right, it's our state prison, federal prison, and jail population. So that drugs explaining how they got there and oftentimes associated with underlying problems related to alcohol and drug use disorders. So within our correction populations, this is the phenomena. Bars on the left represent general population, alcohol use disorder in gray, drug use disorder in red, and then the center bar, jail prevalence rates, and the bars to the right, state prison prevalence rates, over 50%. And that's why we're presenting this information to you at this stage in our conference. The modal individual that you may encounter within your reentry activities will have a substance use disorder that may explain entry into the correction system, but certainly complicates exit from that particular set of supervision. So too, we have an overrepresentation of individuals with mental disorders in our jails and prison. General population, about 5% of us during the course of the year meet criteria for a serious mental illness. And if we then look at our jail population, and this data comes from a study that we conducted in 2 jails in Maryland and 3 in New York, over 20,000 bookings, where we screened for and then followed up with interviews to determine their behavioral health needs, 17% of individuals booked into those 5 facilities met our conservative criteria for a serious mental illness. And teasing that apart further, 14.5% of men and a stunning 31% of women booked into these county jails met criteria for serious mental illness. Drilling down farther, for both men and women, 3/4 of those individuals had a co-occurring substance use disorder. Again, this complicates the ways in which one needs to respond, the services that are necessary to assist in recovery, and the ways in which we can promote public safety. Not all mental disorders are serious, and this has important implication for access to service, for insurance coverage. In this slide from our New York study, we saw individuals with mental health disorders broken down into serious, which is the group on top representing 43, and less serious. Less serious doesn't necessarily mean less disabling. We get to serious a combination of diagnoses, typically schizophrenia, bipolar disorder, schizoaffective disorder, major depressive disorder, duration, having some chronicity to it, and most importantly, the degree of disability that's associated with those diagnoses. But in a non-serious category, somebody with a significant anxiety disorder may be unable to participate in work without appropriate treatment. So not serious doesn't mean not important. And we understand this distinction in that access to services is sometimes determined by that category. So every state that you're from has a definition of serious or serious and persistent or severe mental disorder that's associated with access to care in that community. And so knowing that is important. Historically, those folks that didn't fall into that category, that had no other insurance, didn't get access to care. We now have a new day and a new opportunity with the Affordable Care Act. And in those states that have chosen to expand, now this group of individuals with less than serious mental illness, but below 133% of the federal poverty level, may have coverage that opens doors. And I'll follow up on some of Director Botticelli's points in a moment. All of this occurring in the context of tight budgetary times. And so while we're emerging from the recession, I think many of us on the front lines, I work in a shelter in Charleston, South Carolina, we don't see exactly this great rebound at this point in time. And there have been significant cuts that have resulted in decreased access to care. I'm going to borrow a page from Superintendent Stickrath's book and share with you yesterday's USA Today. I don't know if you were in the hotel yesterday or had a chance to see this, but the above the fold headline is "The Cost of Not Caring." And within this is several important statistics. The fact that mental illness costs about $444 billion in this country, the fact that about $5 billion in real today terms have been taken out of mental health budgets over the last 4 years, the fact that 40% of individuals that have a serious mental illness receive no care in the year prior to this particular study. The result of these cuts mean that services have contracted. And in this slide, these are the number of states that have contracted types of services. And I would draw your attention to the bottom two bars, which is our state acute inpatient and state long-term inpatient beds shrinking. In the 1960s, almost 600,000 beds. Today, less than 50,000 beds. Very difficult to get access to inpatient care if you need it at this point in time as a result of a serious mental illness. And you know this in your communities. You know how hard it is to access services for individuals, and that it becomes another piece of the puzzle that we're all asked to fit together, and in part some of the workarounds that we've been discussing earlier to assure that your individuals get access to the services that they need. What are behavioral disorders? When we use the term, I'm talking about mental disorders, addiction disorders, or a combination of the two. The term behavioral health kind of has a in and out flavor of the day to it, and that there's oftentimes some disagreement about that term. But it's getting commonly accepted to refer to those disorders that we find in our DSM-5 or our standard nomenclature at this day and time. Sometimes we use disorders, sometimes we use illnesses. I've talked about serious, severe, severe, and persistent. We don't want to get too hung up on these terms. They tend to overlap in meaning, but you should know the specificity as it relates to services within your community. So, we have an overrepresentation of individuals with mental disorders and substance use disorders in our criminal justice settings. That's clear from the data presented already. Understanding how they got there can be an important component for designing interventions that mitigate their chances of returning there. So, factors that I'll go over in more detail include arrested at higher rates. Obviously, that's the way you get into the criminal justice system. Some of that relates to the co-occurrence of mental and substance use disorders. If you have a mental disorder, you have 3 times the likelihood of having a co-occurring substance use disorder. A substance use disorder, 4 times the likelihood of having a co-occurring mental disorder. And those conditions in combination can be significantly disabling. And without working, I can't sustain gainful activity or be employed. And sometimes I fall out into our homeless population. Homelessness as a driving factor. We have an affordable housing crisis. It's been a chronic crisis, so it's hard to sort of talk about it with the acuity that we all feel when we can't find a place for individuals that we're working with to live. 2 million people this year won't have adequate shelter. 750,000 on any given night. 10 to 20% of them will meet criteria for serious mental illness. 40 to 50% alcohol use disorders, 15% drug disorders, 20% co-occurring disorders. And a homeless person is a very visible person within our community. Roughly 10 times the rates of homelessness in our criminal justice population than in our general population. And you all know how hard your work is. You all know how multiplied that effort needs to be for an individual that's on a street or living within our shelters. Sometimes homelessness is how that individual got into jail or prison, arrested for public nuisances, panhandling, vagrancy. Sometimes the arrest itself creates homelessness. So now I wasn't around or couldn't work or didn't pay my rent this month and end up being evicted from my place of stay. Both mental disorders and substance use disorders are associated with higher rates of homelessness. What accounts for the problem? Limited access to health care, both in terms of coverage and in terms of quality. So that in a study by Urban Institute, folks leaving state prison settings after 8 months, more than 80% of them uninsured. And without insurance, you don't get into many health provider doors. This results in huge costs to our states and localities. So in this pie chart, there are the funds that are spent on mental health services by our state. We have this circle in red here, which is state general funds. We have the circle in gray over here, which are federal funds. For those states that choose at this point in time to expand the Medicaid population under the Affordable Care Act, we expect that the gray circle component of the circle is going to grow and the red component of the circle is going to shrink. So there is opportunities, as Director Botticelli said, to then use those state funds for other services, for gap filling services, for case management services, for the type of access to housing and supports that are required to fit that piece of puzzle, those puzzle pieces together, and assist people in landing on their feet and desisting from crime and moving on in their productive lives. These opportunities are both in expansion and non-expansion states, so that we have health insurance marketplaces that exist throughout the country, individuals making less than 400% of the federal poverty level entitled to subsidies. And we need to help people know if they're in that category so they can then perhaps get insurance that then opens up those doors. And again, in the 26 states in the District of Columbia that are currently in expansion mode, there really are new opportunities for those individuals who heretofore had no insurance to have doors opened. And importantly, as again, Director Botticelli suggested, we had legislation passed 3 years ago, the Mental Health Parity and Addiction Equity Act, which says you need to treat mental health and substance use disorders at parity with how we treat and provide care for somatic disorders. So we can't discriminate in terms of co-pays, in terms of limits. And again, this is a law that was passed. It's up to all of us to see and ensure that it's implemented within the spirit of the law. That's a test that's coming. All of this kind of combining together so that the folks that we work with have these triple stigma: criminal justice involvement, drug addicted, mentally ill. This all leading to reduced access in housing, employment, in treatment and other services, sometimes a perception of violence of folks with mental illness. If you look at the media headlines, you would think that most violence in this country occurs in the context of mental illness. That is not the case. Most individuals with mental illness aren't criminals. Most crime is not committed by people with mental illness. But this set of biases and stigma lead to discrimination, which again reduces access to care. So there's an access issue that drives our prevalence rates higher. It is also the case there's a quality of care issue, so that we have a great science in the treatment of behavioral disorders that allows us to say with confidence treatment works. Good treatment allows for recovery, promotes independence and self-sufficiency, helps in reducing recidivism. The problem is when I walk into a mental health center or addiction treatment center, I don't always get quality care. I don't get what the science suggests is necessary to get the outcomes that we all desire. And in this particular pie chart here, taken from the National Survey on Drug Use in Households, where 20,000 people answer the phone, not anyone that's in jail or prison, not anybody that's homeless particularly, but answer questions in a survey that allow you to identify behavioral disorders. And what this pie represents is the 2.5 million in the last survey that answered questions that said you have co-occurring disorders, both a mental illness and a substance use disorder. The follow-up question is, what type of care did you get in the past year? Along with the US Today headlines, 40% got no treatment at all, even though the combination of disorders are significantly disabling. Another 45% got mental health treatment only, when we know that's not the evidence-based practice for co-occurring disorders. It's an integrated set of treatments that's required to achieve good clinical outcomes. So, The wedge here is 11%. The good news is that 10 years ago in the NUSDA survey, that was 2%. So there is a growth in co-occurring services, but I'm sure in conversations with you, I will learn that they aren't available in the quantity that's needed for the folks that have them that you're working with. We have an agenda to expand access to evidence-based treatments. Also contributing to the overrepresentation of people with jail and prison with mental disorders, they stay in those facilities longer. Same charge, same sentence. This is a slide from the New York study. Pre-sentenced or sentenced individuals, 2 times longer with a mental health diagnosis. If you're in the state prison, Bureau of Justice Statistics study, 15 months longer if you have a mental illness compared to those with the same charges, same sentences without mental illness. Folks with behavioral disorders don't do well in custody. They tend to get in arguments, in fights. They can be victims. They lose their good time. Nobody wants to send an individual with disorders that doesn't have a place to live out. They have lower rates of parole approval. They have higher rates of maxing out. So they come out without any supervision as a result of their lengths of stay within those settings. It is also the case that they have higher rates of recidivism, not necessarily for new crimes, but in this study of 3,000 probationers, increased rates of technical violations. Tough when I've got schizophrenia to remember my appointment, to pay my fine. With a co-occurring disorder, my urine may be positive. All of these things may result in my coming back into correctional settings, increasing the prevalence of those disorders within our criminal justice populations. The story, though, and David's going to pick up on this, is that mental disorders, substance use disorders, they don't explain entirely how individuals got into the criminal justice system. So it used to be, and this is some of the advances that we understand over the last 10 years, a hypothesis that if I just treated the mental illness, that for that individual would be sufficient to keep them out of trouble. It turns out that the story isn't that straightforward, is more complex, more nuanced, and needs to be accommodated in your programmatic activity. In this study that was released in the Journal of Law and Behavior 2 weeks ago, principal authors Gillian Peterson, Jennifer Scheme, and associates, they looked at 140 participants in a mental health court in Hennepin County, Minnesota. And they did a detailed interview and asked them, how did you end up here? What caused you to be arrested? And in that narrative, they learned that a very small fraction, 7.5%, got there directly related to their mental illness, directly related. I have schizophrenia, I hallucinate, I hear voices, the voices tell me to hurt you, I hurt you, and I was arrested. Another group had it partially related to mental illness. I have schizophrenia, I can't sustain gainful activity, I couldn't pay rent, I'm homeless, I shoplifted, I was arrested. The vast majority of those individuals interviewed didn't get arrested and weren't in custody related to their mental illness. They got in trouble for the same reasons that all of us might get in trouble. Hanging with the wrong people, making some bad decisions, not having any meaningful things to do during the day, poor education, no work opportunities. These are the factors that drive people with both mental illness and without mental illness, with substance use disorders and without substance use disorders, into our criminal justice system. So we need to be a little smarter about knowing who we're working with. These individuals in this study were also asked, had you ever been arrested before? And the average number of arrests were 4 for those individuals. And in those arrests, even in those that got there directly this time because of their mental illness, they were not related to their mental illnesses. So there's something else that individuals need besides treatment, and we're going to discuss that going forward. It turns out that individuals with mental disorders have the central 8 dynamic risk factors in a greater degree than individuals without. An opportunity. David's going to help us understand what that opportunity is. These dynamic risk factors predict recidivism more strongly than the mental illness. And these are the factors that we need to attend to if we're going to help those individuals stay out of jail and prison. We're talking about criminogenic risks, familiar to many of you, but I just want to be clear. We're not talking about crime type or failure to appear or sentence or disposition or charges or custody or security level. We're talking about how likely is that person in the future to commit a new crime or to be brought back in on a technical violation. That's what we're talking about with criminogenic risk. I want to just say a few words on dangerousness because sometimes it gets confused. Criminogenic risk is not a prediction of dangerousness, not a prediction of violence. We have other tools out there that can assist in that, like the VRAG, many of you are familiar with it. A very important component of information that we provide to decision makers because they want to ensure that public safety is preserved. But violence is a rare event. Predicting it is a often futile effort, and that while these tools can assist in creating risk bands for violence, I think it's important for us to understand that's not the issue when we're talking about criminogenic risk. The criminogenic risk is principally comprised of two components. Static factors, can't change them. Dynamic factors, that's where we want to focus our energy. Static factors, criminal history, age of first arrest, gender, men more likely to commit crimes than women, younger people more likely to commit crimes than older people. These are part of your history. Can't undo them. It's the dynamic factors and their associated needs that we want to be focused on. And that this list of dynamic factors, history of antisocial behavior, antisocial personality pattern, antisocial cognition, antisocial associates, family or marital discord, difficulties with work or education, substance abuse. Substance abuse, that's on the list. It's not always a driving factor for folks, but for some it is. And that it happens to be that in many of our behavioral health settings, we do a pretty good job at the bottom four because that's what we were trained to do as behavioral health providers. Help people resolve interpersonal conflict, help them perform better in school, find a job, okay? And increasingly provide treatment for their addictions. It's these top dynamic risk factors that we're not quite as willing, capable, or currently providing services for. And we can change these. These are patterns of thinking and behavior with appropriate interventions that can be changed and the risk of recidivism mitigated. So that's the setup for David Demore to follow on with a discussion of our risk, need, and responsivity model and its application. And we hope that this is something that you embed within the treatment planning and supervision that you provide within your programs. David Demore, the head of our national division overseeing Second Chance Act, Justice Mental Health Collaboration. He's one of those guys that you ask, and we all have him in our organization, how the heck does he juggle all that stuff? David manages to juggle it, and in addition to that, a terrific trainer. David?
Thank you. Okay, so basically what you've heard thus far is you cannot ignore behavioral health when you're thinking about reentry. What you also began to hear is that you can't ignore criminogenic risk when you're looking at folks who have behavioral health difficulties. Historically, we've tended to talk about these in very distinct buckets. And while there are some who might fall into one bucket or another, it is becoming increasingly clear how these are interrelated in so many ways for so many of the people that we see. And I'm quite certain that for the practitioners in the audience, that rings home true, that you've seen these folks, that you're consistently struggling with the issue of, I want to help them, but I don't have the right tools. Is this the right referral for me? I can do this part, but I can't do the other part. And in fact, what it comes down to is how we think better, not only about who we refer to what services, but also how we redevelop and redefine our services and think about providing services in different ways. And so I'm going to talk a bit now about the risk-need responsivity model, which again, I suspect that many of you have heard of or know of. But it is amazing when we go around the country how many jurisdictions have yet to put this in place in the work that they do. So when we talk about the risk-need responsivity model, it is comprised, of course, of three areas: risk, need and responsibility. There's the risk principle, there's the needs principle, and there's the responsivity principle. Well, first of all, let's talk about this issue of risk. And what it has to do with is really focusing our intensity in terms of our response on those folks who have the highest likelihood of reoffending. As opposed to a one-size-fits-all approach, who are the folks that we can best impact? And it's actually a twofold issue. Who are the folks that have the greatest need for what we do? And who are the folks that what we do can make the most difference for? It is not a good use of resources to spend those resources on the folks who will be okay anyway and will do relatively fine without us. So the risk principle really focuses on that. Now, when I talk to many folks about the risk principle, they say, oh, absolutely, we follow that. And so I might ask, well, how do you do that? And they'll talk about a variety of ways that they do that, some of which I'll talk about in a little while around risk assessment. Some of them will talk about based on the type of crime. Some of them will folks still talk about their gut. They still talk about, I know just by looking at them, who it is that I need to be more worried about. Lots of folks talk about, sure, we assess them, but we have override functions, and they end up overriding 40, 50, 60% of the individuals that they have assessed, thereby making those assessments absolutely meaningless. So people understand that the risk principle is a required principle to have a good impact. But in terms of implementation, people are still falling behind and are still too often overriding the principle out of concerns that somehow they can see the problem a bit better than what the tools are telling them. And we're going to argue that that is actually not accurate. In fact, when people don't adhere to the risk principle, they increase failure. This is a study from some halfway houses in Ohio. And what they found is that when folks did not adhere to the risk principle, they actually increased the failure rate of folks who were in the low risk category by about 3%. They actually caused people to fail through their interactions that if they had left them completely alone would have done well. Imagine how much money was spent to help those folks fail. Not a good use of resources. They also found that when those same programs were utilized with folks who were of moderate or high risk, that there was in fact a significant decrease in recidivism, 6% in terms of moderate risk and 14% in terms of high risk. And that's something to really celebrate, because that is what we should be about, helping the folks that are most likely to not make it be able to make it once they get out. So if we look at the history of how we did this, there was a time when basically we didn't assess risk and we talked about failure rates, and we would say, oh, you know, there's a 50% failure rate, or there's a 60%, or there's a 70% failure rate. And we would lump everyone together, and we wouldn't think about this issue of who was in low, who was in moderate, and who was in high. And then we began to develop risk assessment tools. Some of them include the LSIR or the LSCMI or the ORIS, the Ohio Risk Assessment, or the COMPASS, just to name a few of them. And we began to develop these, and we could now tell who fit into different levels of risk. But we still did not routinely adjust our case management, and so we were seeing folks with the same types of case management, same types of supervision, even though we had a different score for them. And we still were doing a lot of overrides. And then as more time passed, we began to get better at saying, no, wait a minute, we actually have to categorize these folks. We need to determine who is in what category. And when we start looking at what we're going to do in terms of our services, which we do not have enough of in terms of providing for everyone, we need to really target those folks who are in the mid-moderate or upper moderate and high risk first. Now, that doesn't mean that folks who are low risk don't have needs. They do. The question is, where do they get those needs met? And we'll come back to that in just a little while. It does mean that what their needs are not intensive supervision or are not intensive programming that is aimed at those folks who need to, for example, change their antisocial cognitions in order to not reoffend. The second concept is the needs principle, and the needs principle is talking about targeting the criminogenic needs, those risk factors, those dynamic risk factors that you heard Dr. Osher talk about, including things like antisocial cognitions, antisocial behaviors, substance abuse, antisocial attitudes, and criminogenic peers. So what it is that can be targeted. What is a key issue is that they are the dynamic risk factors. In other words, they're the things that can change. You can't change criminal history, you can't change what the actual offense was, etc. These are the areas that good supervision focuses on, and these are the areas that good criminal justice treatment responses focus on. These are the areas that are responsive to cognitive behavioral interventions. I do want to make a quick point here about this issue of criminogenic peers. Very often you see supervisors misinterpret what that means, and of course we often have a standing law, you may not be around someone else who has been convicted of an offense. Well, that actually makes sense if in fact that other person who's convicted of an offense has the criminogenic thinking and is still doing bad things. It actually doesn't make a lot of sense if you have individuals, as we have many, who have gone through the system, who have gone through programming, who have indeed developed very, very solid ways to live, very pro-social lifestyles, and who can mentor and help those who are coming out. And so sometimes officers or providers or policies sort of shortcut, and they say, you can't be around a person with this label. It is actually a much better plan to say you cannot be around a person who exhibits these types of behaviors or these types of thinking, because we really lose a very important opportunity to help folks and to help folks continue to develop who have done well by disallowing those connections and those interactions. Now, you saw 8 criminogenic needs, and a lot of times people go, oh my goodness, I can't possibly do all of those. There's so many of them, the cost involved, the skill sets involved. Well, there's some good news. You don't have to start with all 8 at once. That would be great, it would be ideal. But the truth is that we often have to build this up over a period of time. What this chart shows in a very colorful way is that if you ignore all of them, you basically help people fail better, right? To the right. If you just hit 1, you actually do slightly better than 0. It's nothing to write home about, but you do slightly better than 0. You're not making them worse. You're not making society less safe. If you start hitting 3, you see a significant impact. And as you start building up, you see more and more of an impact. And indeed, if you hit all 8, that's wonderful, but you don't have to start there. You have to start with 1 or 2 or 3, ideally, and you work your way up. Right? You don't have to hit all of them all of the time. There is no excuse to not do this if you cannot do all of them at once, if you cannot respond to all of them at once. The third piece, or the third principle, is the responsivity principle. And this issue is basically tailor the intervention to the learning style, the motivation, the culture, the demographics, and the abilities of the offender. We do less well with this systemically. We do less well with this. Even from a research perspective, we don't have as much good research, but we know that it works. We know from education theory and education research, we know that it makes a significant difference, that expecting all folks to respond to the same thing in the same way doesn't work. I often use these workshops as an example, because the fact of the matter is that what you are all doing today is listening to a number of folks speak at these various plenaries, and if you're an auditory learner, that's great. Some of you are not auditory learners, and you're really glad that those pictures are up there. Right? I know the people that are visual learners because you're not looking at your BlackBerry. You're looking at the pictures. The auditory learners are listening to me and looking at their BlackBerry, and they're able to do 2 things at once because really they learn by listening. And then some of you are no doubt kinesthetic or learners through experience, and this is not a good session for you because we won't be doing any of that. But all of you are deeply motivated, indeed even paid, to be here, and all of you are professional and highly educated, and you know how to compensate for that. But if I were truly trying to develop a very lengthy, week-long kind of process, we would have 10, 11 different ways of learning that we would be working with you all about in terms of moving that forward. So the idea that everybody learns by completing a page in a chapter in a book, or everybody learns by sitting in a group and recounting what they wrote, or the fact that not all people can necessarily even read what it is that we're asking them to read, doesn't make sense. And so the content is important, but the style and what we do has to change. Now that's one type of responsivity. The other types really have to do with what Dr. Osher was talking about in terms of mental illness, which is clearly a responsivity issue. And even if it is not directly a criminogenic factor, it is clearly a responsivity issue. And substance abuse is both a risk factor and a responsivity issue. So that actually would fit in the middle of this circle. And too often we do one of two things incorrectly around this. We either say, you need this, and we say you need mental health treatment or you need substance abuse treatment, and that's all you need because there's your problem. We not often enough do we say you need some integrated mental health and substance abuse treatment, even though so many of our folks have a co-occurring disorder, so we don't even do that. And then many times, particularly if they have a mental illness, we actually disallow them coming into the cognitive programming that we're doing. And yet, as Dr. Osher told you, for a very significant number of these individuals, the drivers, what got them there, wasn't actually a direct result of the mental illness, but was a result of the same criminogenic factors that got other individuals there. So when we're talking about people coming in, and more importantly, when we're talking about people coming out, we have to respond not just to the mental illness issue, not just to the substance use issue, not just to the criminogenic risk issue, but depending on who the individual is, we're going to need to respond to all of those, sometimes at the same time, sometimes no. You have to stabilize folks first before you move into the cognitive work, but that's what you do. You stabilize them and move them into the cognitive work as opposed to you simply don't see them. All right, we know that the most vulnerable time for people returning to the community is right when they come back in the first several weeks. There are elevated health risks immediately following release. There's higher risk of drug use. There's a 12-fold increased risk of death in the first 2 weeks after release. But if we do really effective transition planning and implementation, we can minimize the risk of those hazards. We can enhance public safety by increasing the possibilities that folks will participate and complete supervision, as well as their treatment, and that we can promote recovery and improve individual outcomes. Those initial weeks are so deeply important. It is also important, in addition to talking about risk factors, that we think about protective factors that folks have. Protective factors aren't just the absence of a risk factor. They're the things that folks have built into them. Sometimes we talk about desistance factors, right? They're the things that people have built into them that help them do well. There's a lot of reasons why we should include it when we do risk assessment. It helps us have a better view, a more balanced view of the offender. It increases our predictive validity when we look at both risk and protective factors. It helps increase that therapeutic alliance between us and the individual. And to be clear, though the word is therapeutic, that therapeutic alliance isn't just with clinicians and clients, it is also with supervisors and supervisees. People only change in certain ways, and it doesn't matter what our job is. There are certain ways you get people to change, and there are a lot of ways that you don't get people to change. And in addition to that, it really is sort of a mandate that we look at, we are as professional as possible, and we look at all of the different areas that an individual has and that we respond in the most appropriate fashion. There's this neat quote that says, treatment is not just fixing what is broken, but is nurturing what is best. I like to change it and replace the word treatment with intervention, because as I just said, it's not just the clinical intervention that is relevant. When we're talking about this, it is all of our interventions. All intervention is not just fixing what is broken, it is always nurturing what is best. Now in 2010, NIC commissioned a framework and asked us to work on the development of this framework, specifically focusing on the issue of working with people who have mental illness who are in corrections. And fairly quickly, NIC determined, along with ourselves, that we needed to expand that concept a bit. And so as we talked with them and we talked with other federal partners, the Bureau of Justice Assistance and SAMHSA, the Substance Abuse and Mental Health Administration, also came on board and joined and added resources to do the work. We realized that if this framework was going to make sense, we needed to look at all three of these areas. We needed to look at what works in substance abuse treatment, we needed to look at what works in mental health treatment, and we needed to look at what works in recidivism reduction. And so these three areas are the areas that we focused on in terms of developing a behavioral health framework. And that framework was published about 1.5 years ago now, roughly, and is available on the website. What is important is not only did those federal partners come together to join, but so did other significant organizations, including the National Association of Mental Health Program Directors, the National Association of Substance Abuse Directors, the American Association of Probation and Parole, and ASCA, the Correctional Administrators Association. We felt it was imperative that all of these folks be involved. We felt that it was imperative that if this framework were to be a useful tool, that the various disciplines involved needed to be able to work together on developing it, needed to be able to sign off and agree that this made sense for our various disciplines to work on. Now, as you heard earlier, not all substance use disorders are alike, and they go from mild all the way up to severe, depending on the number of criteria. So there are some folks that have what we might call substance use issues. There are some folks that we would say have abuse issues. There are some folks that we would say have addiction issues. It is a continuum, and to suggest that all substance use disorders or needs are the same does not make sense. We also know that not all mental illnesses are alike, and that there are folks, of course, who have, this is a general population chart, to be clear, not a criminal justice one specific, but you know, about 16% of the population has diagnosable mental disorders, about 5% have what would be called serious mental disorders, and about 2.5% have severe mental disorders. So again, not all folks who have a mental illness are the same. Well, several years ago, Nazadat and Ashby developed a concept, a framework for looking at the population that had co-occurring mental health and substance use disorders, and our own Dr. Osher worked with them, in fact, on the development of this framework. And basically it had two axes, and it was looking at low and high severity of mental illness and low and high severity of substance use, and then looking at where you fit in between the combination of those two and what type of services made sense. What we did was build on top of that groundbreaking work and add this third component, which is the issue of criminal justice risk on a continuum. Because not all criminal justice risk is the same. Some folks are low, some folks are moderate, moderate high, and some folks are very, very high. And so to really improve the accuracy of the work that we're doing, to improve the efficacy of our systems, we felt that we needed to add this component. Thus, we came up with the behavioral health framework. And the behavioral health framework starts by looking at the issue of criminogenic risk. And it breaks folks down in terms of low and then moderate to high criminogenic risk. The first measure, the first issue, makes sense, right? We are working in the criminal justice system. The first thing that we need to look at is what are the criminal drivers that got that individual there. The second component of the framework looks at the issue of severity of substance use. And it looks at that severity in terms of low and high, both under those who have low criminogenic risk and those who have high criminogenic risk. So now when I've seen someone, I'm looking at their criminogenic risk and I'm looking at their substance use need. Then we added a third component, got a little bit more complicated, and we started looking at the issue of mental illness and mental health need. And we again broke this down in terms of whether they had a low or a moderate to high need. And you can see that what we did was allow for that possibility in all of the categories. So we have now gotten more complicated, right? We went from 2 large buckets to 4 not so large buckets to 8 more discrete buckets. And it allows us to better understand the individual's in those different buckets and what they need. And by the way, just let me be clear, this is not a tool to assess individuals. This is a systems planning tool, because the issue becomes, is the system providing the right types of programming for the different types of individuals? And then the second issue becomes, is the right system providing the programming? Because the correctional system would need to provide certain types of programming, and the mental health systems or the substance abuse systems or the combined mental health substance abuse systems, depending on your state, would need to provide those other services. And ultimately, that gave us 8 groups that we looked at with different variations of high, moderate, and low in these different areas. So as a system, we can now look at where folks fall into these different areas based on the various risk assessments and tools that we use, and think about what kind of resources do we need to put into these different areas. So what about the application of that framework? Well, there's 2 things that have to be looked at. First, the target population, which is what I've basically just been talking about, right? Who fits into what category, who fits into which of the 8 different boxes, if you will, that we have there. And then the second is, what is the availability of comprehensive and effective community-based services? And if they're not available, obviously, how is it that we develop those over time? Because the issue is to be able to develop effective interventions for each of these subgroups. And when you look at these various subgroups, if you want to have a simple cheat sheet, if you will, the 4 groups on the right, those are the ones that probably really need to get many of their services under the correctional banner, if you will, that corrections needs to pay big attention because their highs that include high criminogenic risk. Whereas the folks on the left-hand side, the first 4 boxes, many of them do not need heavy correctional intervention, they fit into that low-risk category. They don't need us to be spending correctional resources, but they need good mental health treatment services. They need good substance abuse treatment services. And those services can come or should come from the community and from typical kinds of service providers as opposed to being combined specifically with correctional services. It's assumed that whatever responses are developed, that they will utilize evidence-based practices as well as promising approaches, that people will be paying attention to fidelity, so they will be assessing the programming. There will be ongoing testing and evaluation of those programs. The framework supports implementation in a number of ways. It really looks to advance collaboration and communication by helping folks develop a shared language, by helping them develop common policies between criminal justice and behavioral health systems, by helping ensure that the scarce resources are more effectively utilized, by promoting the use of validated assessment tools in order to gauge both the individual's behavioral health needs and their criminogenic risk, in short, to help identify the right people for the right responses. It also helps in terms of promoting effective practices for matching the individual's risk and needs to programs and practices that are associated with what the research tells us makes a difference, and to help refocus transition and reentry efforts for folks that are leaving prisons in order to give them the necessary skills. In other words, to look at how we change our programs. We need to stop thinking about just who are the right people to come here. We need to start thinking about how can I be the right program to serve the majority of the people that have the greatest needs in terms of lowering their recidivism. The framework can also help improve continuity of care and community integration through the development of policies and practices that help folks share the necessary information across systems. Now, of course, there are a number of challenges to what I've just described, and I'm sure many of you have been thinking about some of them. They include that we often don't assess risk and need and behavioral health needs soon enough after someone's charged. Sometimes weeks or months go by. We don't often communicate those assessment decisions very well. Mike's story this morning. We often tell the story badly. We don't often use the information to inform services and supervision. I've been in many jurisdictions, great big file, lots of great data, and yet everybody's getting the same type of supervision and the same intensity of supervision. We have the difficulty of providers both, excuse me, not just supervision agents, believe it or not, even supervision agents, but also community providers to serve those high-risk folks. People's jobs are frankly difficult enough, and it's like, now you want me to serve those high-risk folks? And even talking about them as high-risk sounds scary, but of course what we're talking about is the issue of the likelihood of them recidivating. As Dr. Osher said, we're not talking about the issue of dangerousness or things to be fearful about specifically. And the other issue is, of course, that we have to ensure that the treatment system has the capacity and skills to serve the populations that they wouldn't otherwise see as a priority population. What is our goal? Our goal is really the development of universal screening. To conduct universal screening as early in the booking and intake process as feasible, because reentry really does begin at that point. And throughout the criminal justice continuum, in order to detect substance use disorders, mental disorders, co-occurring substance use and mental health disorders, and criminogenic risk. And it's not a one-time assessment process. It is starting early. It is often early on a screening process for the target population, short form kinds of assessments that just take a little while to do. For those folks who have a positive screen, then that gets followed up with more comprehensive assessments in order to guide the appropriate program placement and service delivery. As Dr. Sarah Desmarais says, and she will be speaking at some of our different workshops through the week, the goal of risk assessment is not simply to predict the likelihood of recidivism, but ultimately to reduce the risk of recidivism. To do so, the information that is derived during the risk assessment process must be used to guide risk management and rehabilitation efforts. And yet, still today, in many jurisdictions, you do not have risk tools being utilized. It's amazing, even today. Even more problematic is that in many jurisdictions you have them being utilized, but they're not necessarily validated tools that are being used, they're homegrown tools. And in other jurisdictions they're using validated tools, but as I mentioned earlier, the override is so significant that they're spending a lot of money for really very little outcome. So the goal is A, universal screening, B, using the right tools, and C, developing the programming based on the information from the universal screening and using the right tools. Three-step process that needs to be put in place throughout our systems. Now, there are a number of services and supports that have been associated with good public health and safety outcomes. There are a variety of evidence-based practices and programs out there, assertive community treatment for folks who have a serious mental illness and are in the community, supported employment, integrated dual diagnosis treatment, psychopharmacology, again, not used as often as we would like, as you heard this morning, and of course the cognitive behavioral therapies. There are also a number of promising practices and programs that are out there. The research isn't yet fully in, but the initial information is very, very promising, and these include things like forensic ACT teams, forensic intensive case management, supportive housing, peer support, forensic peer specialists, and modified therapeutic communities. So we have a number of things that have been shown to have an impact. And of course, there is the issue of cognitive behavioral treatment, in which there is clear information that shows that when you target that treatment to folks who have the high incidence of criminogenic risk, programs such as reasoning and rehabilitation, such as thinking for a change, such as moral recognition therapy, which are three of the more common ones that are utilized, that you have an impact. What we're really looking to move to is not just that issue of the goal of universal screening, right assessment, right program planning, people being put in the right programs, but the issue of integrated treatment responses for both criminogenic and behavioral health needs. And when you look at the studies, what you find is that you get the best outcome when you have good supervision and good treatment when you're working with higher risk individuals. You're talking about an integrated response of intensive supervision and treatment-oriented programs for moderate and high risk individuals. Again, not for the lower risk folks. much more impactful than drug treatment by itself, which in no way is to suggest that drug treatment is not important, much more impactful than employment training by itself, which is not to suggest that employment training and jobs are not extremely important, because of course they are. But what we're really saying is that those need to be wrapped up in all of these other components of treatment and supervision. In closing, as they say in various ways, and have been quoted, multiple people have been quoted as having said this, every system ultimately is designed to get exactly the results that it gets. And so if we want to lower recidivism, it's not the issue of getting a better class of client. If we want to lower recidivism, it's not the issue of doing the same thing that didn't work more. If we want to lower recidivism, it means looking at what our system does that is ineffective and what our system needs to modify in order to be more effective with those folks who are most likely to recidivate. And over the next 2 days, you will hear from a variety of individuals about what the research tells us are the most effective ways to intervene with folks and are the most effective ways to help folks not return to prison, not remain in the criminal justice system, and to lead both crime-free and also productive lives.